primary care is not a specialty per se, but rather a function that can be served by people who are trained in internal medicine, people who are trained in family medicine, people who are trained in pediatrics and OB-GYN. And as a result of that, we have not regarded it as well, and yet we put a lot of weight on it. And with the what I call the corporatization of healthcare that really began in the 80s, we saw that primary care providers were required to become or expected to become the gatekeepers, determining who saw what specialists when. And that in many ways corrupted the doctor-patient relationship between the primary care physician and the patients they serve. And patients began to think of their primary care doctor as someone who was a potential obstacle for them getting maybe access to a specialist they felt they should be seeing. It takes a long time to establish a good and a positive relationship with a primary care physician. But as I said, we have a lot that shows us that that is useful, that patients who have access to primary care and have a relationship with a long-term relationship with a primary care provider, it results in longer and healthier lives. And yet, while this is such an essential function of our healthcare delivery system, only a third of the providers in our healthcare system in the United States are primary care providers. That is a challenge because people do not necessarily have access to what they need. And only 5% of healthcare expenditures are spent on primary care. And most people would say that we would need to do something, we would need to double that in order to improve the access. But as I alluded to, primary care providers are not necessarily well regarded within the healthcare delivery system. And oftentimes young physicians coming out of medical school and selecting a training for their career opt not to go into primary care because they have a lot of debt and they're concerned about how they will pay that debt over time. And so it's not one of the glorified or sexy specialties that people consider. And during the COVID pandemic, there was further erosion of folks serving in this role. There were many patients to be seen and not enough access. And folks have struggled to meet an ever increasing demand. And so we're going to talk about what's happening today and how we'll get there as we look at the percentage of physicians coming out of medical school and what percentage of them go into primary care specialties. That has not been increasing. There are projections that I saw more than 20 years ago suggesting that we should be training 80% primary care physicians and 20% specialists. We had a goal, a modest goal, to get to a 50-50, and we've never achieved that goal in the United States. And as a result, folks have a hard time finding someone who can provide those services, who can help them navigate. Primary care physicians act as advocates and navigators for their patients. They often have to interpret or help our patients figure out what the best services are for them and where they can access them. So I hope that we'll have a robust discussion. Recent articles have shown how corporations are now purchasing primary care practices, and you wonder, what does that mean and why is that happening? And I don't know about you, but I'm always suspicious when big money suddenly starts to pour into an area that has been long neglected. So I hope that that'll be part of the discussion today. So we're going to take a little time to ask each of our panelists to talk about, from their perspective, what they see as the biggest challenges facing primary care today, and how we can pivot as a society. What would it look like if we could get primary care to be privatized? I mean, not privatized, prioritized, so that patients could begin to see or have access to the primary care that they need. So what are recommendations, or what are your thoughts about how we start to move in a different direction? And I'm going to start with Dr. Reinhart.
Well, I think the others here will have perspectives from inside the field be more valuable than my own. Part of my own approach this is to think about the very concept of primary care itself and what constitutes it, how we define it. And one of the biggest problems, I think, in healthcare writ large, including in healthcare in the in primary care in the US, is the medicalization of care. So when we talk about primary care, if you didn't know the lingo of American medicine, you would think we're talking about basic social care, the things that people most need in order to prevent disease and live healthy lives. It's housing, it's food security, all these kinds of things. And this is not at all what we're talking about. We're talking about primary care. You just listed off the specialties, for example, the training routes that one can pursue in order to arrive at a primary care provider status. That inside that list, it's not just standard that everybody is thinking about. For example, community health workers, lay caregivers, all of these people who should actually make up the backbone of an effective primary care system that meets basic preventative needs. You don't need internists necessarily to provide a lot of the things that we currently think of as primary medical care. We're taking for granted the medical part, and in the process often desocializing what needs to be given to people that they're not getting. And there's this, I'm sure several of you know much more about it than I am, but Stat News recently had a profile of David Ansel and the this initiative at Rush, the kind of anchor institution model. And one of the things that stood out in that profile in particular is when they did a community needs assessment, nobody said that they wanted more clinics. Nobody says they need more medical care, even though these are communities that really need medical care from an epidemiological systems level perspective. But what they needed much more are these basic services that we're not giving them. So I think redefining primary care to demedicalize it, at the same time, they're recognizing that the medical aspects we're talking about now need to be dramatically expanded and are deprioritized and underfunded. But coupling that with a redefinition of the very basis of primary care, I think, is going to be important. And then, there have been, since I was in medical school and long before, initiatives to try to push more people into primary care, to incentivize them to do so. And a lot of it is moral discourse, the idea that this is a really important public service that people can play, but we're not changing in a substantive way, at least not enough, the compensation structure that incentivizes institutions to employ certain types of physicians and to provide certain kinds of care. And this is the billing apparatus that we have. I've written a piece with Dan Browner, a colleague of mine, the British Medical Journal. It's called A Critique of Clinical Economy, that traces the AMA's role in producing the billing infrastructure that now really deprioritizes in a systematic way primary care. We have to address the billing infrastructure that motivates all of this. So those are some provisional thoughts, but I'm curious to hear what the others here have to say.
Dr. Conway.
Thank you. So I have a lot of different thoughts. I think that where I would start with is, obviously there's got to be a push, I think, from a policy perspective, maybe from a governmental level, that puts pressure on our corporate structures in order to create some real change. One thing that comes to mind is a couple of times a month, I actually work at one of the hospitals. I won't give a name, but honestly, this is not my experience at that hospital is not very different. And even though I'm a hospitalist, which some people don't think is primary care, in many ways it is primary care, especially if you're working in a public hospital. And one of the things that's pretty common when you are at these hospitals and you're on call, and I don't know how many people in our audience are aware of it, but many times you're the only doctor that is actually servicing an entire hospital. The phones are going off sometimes every 30 seconds. And because the way the model is set up, there is not considered an investment in having more than one doctor, 2 doctors, or even 3 doctors, because they actually want to make sure that they can save money. So you use one person, and what's at stake is you can't be in 4 and 5 different places. You can't be at a rapid response at the same time that you're admitting someone, at the same time that you are writing orders and doing other things that need to be done for the patients. So I think that one of my concerns is that there is not a push and a pressure from a public policy perspective that puts pressure on insurance companies, on hospitals, to make sure that we have adequate staff that are in place to take care of our patients. So that's one thing that really hits home. And because of that, a good portion of my work these days is not just trying to get more diverse faces into these medical spaces, but also teaching our young people that pursuing a track in health policy is super important, because we actually need people who understand the system, the very broken system, to advocate on behalf of the patients that we are actually serving. So those are some of my preliminary thoughts. There is a real concern from the corporate model, which I think is how we deliver care from a corporate perspective, a money perspective.
Thank you. So far, Dr. Reinhart and Dr. Conway have pointed to something that, you know, I would say 40 years in the business is a kind of obvious to me that we've talked about, is that we need a broad-based social movement that demands a fundamental restructuring, and that we could achieve better outcome with less. And that points to the fact that we have a profit-driven healthcare delivery model in the United States. And so as having worked for these many years as a primary care physician, you know, I'm going to start it off with saying if we just would look at a single payer national health insurance, instead of allowing people to make decisions based on profit, but instead making decisions based on population needs, we'd be in a better place. And Steve, I'm sorry to preempt it, but it just seems like it's going in that direction. And I just have to say it because the reason we're in trouble with primary care is because we have large systems that are making profit-driven decisions instead of making decisions based on the needs of the population. And we've never educated the workforce that we need. And so it is absolutely correct that, you know, primary care is a team sport. And so in order to be successful, we need not only a trained provider, but we need a collective team to help and organize the work that has to be done to meet the needs. And then I'll, before I hand it off to Dr. Rothschild, remind you that if you're going to talk about this in a realistic fashion, then you have to acknowledge what my mentor, Linda Ray Murray, has always taught me, is that everything is health. And so having safe housing, having safe food to eat, having safe transportation, having a place to exercise, that is all a part of health. And so we as a society, we spend enough on healthcare in the United States today. We allow too many people who are not engaged in the delivery of care to take profit from it. And as a result of that, we make decisions that shortchange the needs of the population we're trying to serve. But as the chair of family medicine for one of our large health centers, Dr. Rothschild has worked in primary care. I'm sure you have a perspective as well about where we are and where we are now, and talking about how we can make that pivot to where we want to go.
Yeah, thank you very much, Dr. Fegan. Actually, before I do that, I want to make sure we really have a common understanding of what primary care is about. I typically begin with Barbara Starfield, who was a pediatrician at Hopkins, described as the 4 C's, being first contact, where you enter the medical care system. And I love the fact that Dr. Reinhart distinguished the healthcare system that includes food and water and safety and green space and education and so on. That really is part of what primary healthcare should be about. So first contact, continuity, a relationship, and that was a word, Claudia, that you leaned into in the introductory comments, comprehensiveness, and coordination of care, making the connections. More recently, Andrew Bazemore, who's a family physician, added 3 more C's to Starfield, one of them being community engagement, the work that Dr. Reinhart described, David being involved in looking at root causes that don't have to do with you're not taking enough hypertensive medications. Patient-centeredness, focusing on what are the goals of that individual patient, and complexity, which is an increasing issue in primary care. So when you think about those 4 or 7 C's, there's no way that any individual can possibly execute on all of those. The dollars tend to flow towards a physician's service, the time I spend and the code I drop, but doesn't include the work of community health workers, doesn't include the nurse, the health educator, the pharmacist, and all those other pieces that if we're going to execute, you know, we're going to do this comprehensive primary care that really makes people better, we need to think about a funding structure that isn't about the widgets coming down the line, the patients coming down the line. As to why we're here, you know, I want to pull the camera back to not just the ideology around healthcare, but really the market ideology in the United States for at least since the Reagan years and probably well before that. A recent report by the National Academies of Science, Engineering, and Medicine described primary care as a common good. Mm-hmm. You know, a common good is something like public education, public libraries, safe roads, safe drinking water, green space, and so on, you know, fire departments. And for the last 40 years, we're seeing a deterioration of all of those common goods because the ideology that we have been taught with, you know, we have been left with is the private sector will do everything better than the public sector. And is it really so bad if people are evaluated by the amount in their bank account? So that shouldn't people who are wealthier get better care? And so what happens is we underfund public schools. Everybody goes, oh, public schools suck. And then some venture capitalist puts money into charter schools. And suddenly they are held up as the ideal. And in fact, even you get idealistic people who want to make a difference moving to that. And you see that same thing going on in healthcare. You see private dollars coming in. They're putting offices in sometimes in communities that have not been well served by healthcare systems. They're saying we can do this. They're providing team-based care. They're doing all the right things. And then lo and behold, there's profit there and CVS buys it out for $10 billion, as happened in the case of our own local Oak Street Health. The quality of care was good. The people who moved to it wanted to make a difference. But ultimately what happens is we take a public good, something that's necessary for the survival of society, and we move it into a private sector. And unless we name the dominant ideology that's pulling that all, you know, that's making that happen in all aspects of American life, we're swimming upstream.
Yeah, so we monetize the essential common good that we're talking about. And so, you know, going on that, so we see corporations that are buying primary care provider practices. And so sometimes you wind up with one company owning pharmacy, the insurance company, and the primary care office. And so that, you know, when they do that, you begin to, as I said before, you corrupt the doctor-patient relationship, right? The successful doctor-patient relationship is a patient believes, and you as a physician do have their best interest at heart, right? You're their advocate. You're going to help them navigate the system and get what they need. And you're going to try to provide the services, whether it's education, because you delegate a nurse to educate them about their condition, or whether it's a particular type of therapy that you're trying to get for them. And so when we have these sort of corporate monopolies, if you will, you know, what kinds of policy do we need to protect patients and providers from the profit motive driving their decision making, as opposed to what is probably the best thing for this particular patient? And it varies in terms of what you would advocate, even with the same condition. What you recommend for one patient versus another varies by their living situation, where they are in life, what their other needs are, and what is their, their family setting. So I'm going to start with you, Dr. Rothschild, in terms of what you think are in the way of policies that we need to be looking at to protect patients and providers from this profit motive.
You know, the profit motive is so pervasive, but I think the vertical integration that you talked about is particularly one that I would want to call attention to, where the same corporate structure that owns the pharmacy, owns the insurance company, owns the care delivery system. Because when that happens, all of us, because we are all patients at some point, all of us become the product, right? We are no longer partners in service of a greater good, of trying to improve health, improve longevity, reduce premature disability, but we become the profit line. And so I think it is important to break up that vertical integration. I also think the other place, and we've touched on training a few times, and I have to speak to self-interest here as a medical educator, is, the dollars, institutions get, dollars from Medicare to train the next generation specialists. And they get just as much if they are training, there's no strings tied to that. So they can train neurosurgeons, they can train orthopedic surgeons, they can train dermatologists, or they can train family physicians, general pediatricians, general internists. There's no distinction between that. And that to me is a failing on the part of Medicare and CMS to drive dollars to where we want, where everybody agrees we need more healthcare workers.
Yeah, there's no question about that. I mean, it does affect your decision making, because if you are a PCP within one of these integrated systems, it's going to dictate who you refer to, when you refer, and under what circumstances. But Dr. Conway, do you have comments in terms of policies that you think that we need to be looking at to protect patients and providers in their
Doctor, thank you so much. Dr. Rothschild really took the lead in what I was actually thinking about. I really feel like there can be a novel solution that comes from within our government structure. And to piggyback what Dr. Rothschild was saying about residency, I think that we do as a nation have a responsibility to increase the number of trainees in our country. And what if there were a model where the government would decide that we will open up the gates so that we can actually train more people, so that there's more of a duplicated system. And what I mean by duplicated, meaning not just one resident that's on at nighttime. It's insane. Or one resident that has to see 30 people in a clinic. How about we actually lead the charge, our government, and through policy decide that, we're going to have a robust trainee system, and we can actually open more medical schools because we'll create more spots for them actually to train. And how about our residents can then take on a lot of the work that needs to be done, because they could care for more patients in their clinics if there were more residents to actually see those patients. So I really am thinking that if we could actually expand our residencies, we know that's where that was so aptly described, that's where the bottleneck occurs. If we can actually open up our number of trainee spots, that might be a real way that we can create a different kind of system that actually that puts some reliance on the trainee program. You can actually have more trainees and just several actually academic doctors that are training them and still be able to take care of more patients than a single doctor that's out there by themselves in a community setting trying to take care of 30 and 40 people because their corporate system has decided they should be able to see 30 people in a day. So perhaps if our academic centers are able to take a lead because our government decides to open up training spots and really create a model, not just to train residents, but to also integrate them into our healthcare system, I think that might be a way that we can provide, more help and relief to our patients. I also think that there is an obligation on the part of our government to recognize the fact that we have shortages in specific communities of needs, underserved and underrepresented communities. We also know that Black and Brown people specifically tend to return to the communities from which they came to serve. That was all I talked about when I grew up in the Inglewood community. When I got my chance, I'm going back to the Inglewood community. Well, instead I ended up going to the West Side. Same thing though. my goal was to go back and serve. And that's not an uncommon goal. So if we want to be able to relieve some of the pain and suffering that is really happening in our underserved and underrepresented and vulnerable communities, I think it is a responsibility of our government to look at our academic structures and to really help train more students for the pipeline, because they often say that, you know, well, we want qualified people. Help us to train qualified young people from the inner city. Give money to the pipeline programs so that we can get these kids who are talented and smart and bright, get them the resources. We know that they're coming from under-resourced schools, but yet they have to compete in the same system. You take a kid that's growing up in the Nutria system or growing up at Hinsdale Central, their education, no matter how you slice it, unless you are lucky enough to go to a selective enrollment school, kids that are growing up in the Chicagoland area that can't get into Whitney Young, can't get into Walter Payton because their parents are not helicopter parents, because they don't know to be helicopter parents, those kids are not going to have the same resources of kids that get a chance to go to those schools, or Hinsdale or New Trier or some of our suburban schools. I think it is a responsibility when we look down the line that the government helps us to work on managing our pipeline, because there's talented young people that are in the inner city that will actually go back and serve. When we look at the numbers, you know, we talked about this a few years back, that in 2030, we were going to have an explosion. And I think we're almost there already, where there would not be enough healthcare providers. I feel like we're already there. We've seen those numbers. We've got to invest in the pipeline. And a lot of times when you talk to these universities, they tell you, I can't. Yes, you can. You actually can. And if you're getting dollars for Medicare, then you should. And it should be required upon you to help with the training of the pipeline, because these are the people that are going to relieve the pain and the suffering. They're going to go back in the community just like I did. And we need more of that.
Yeah, thank you for that. I might add on to that, maybe one of the ways you approach that is that you have fewer spots available for these super subspecialties and more spots available for primary care. Because, you know, that's really the pain point, is that we are spending a lot, but we are focused on the specialties which are more lucrative for the hospitals, but not enough on the primary care. Dr. Reinhart, do you want to add or have a comment on this in this area?
Yeah, everything that both Dr. Conway and Rothschild have said has been quite provoking for me. And I think is really important, especially this aspect of trust. So, you know, Dr. Rothschild mentioned the 7 C's around primary care, and the contact, first contact. You know, it's assumed that often within primary care that the first contact is going to be a doctor, where it should be somebody in communities. And those need to be valued positions. When we're talking about pipelines, it shouldn't just be about, I agree with everything Dr. Conway said, but not just about pipelines to become doctors or even nurses, but pipelines to dignified, publicly employed, well-compensated union jobs as care workers in communities. Whenever I bring this up, one of the things people often say to me is, what about a ladder? You can't just trap people in that. And what they're assuming in that is that we're talking about poverty positions, like undignified home care work where people don't have job security, they don't have proper compensation, where it's not dignified work. Why are we taking that for granted? We have, for example, police officers, 13,000 plus police officers in Chicago who have great compensation, great benefits. You know, we can have good public jobs. We've just delegated them to sectors that are not about care. Being a home care worker, being a community healthcare worker should not be something that you should be trying to climb a ladder to get out of. We should make that a really important job that people would commit their entire lives to, because that's how you really give back to your communities, not just by being a doctor. And so I think, you know, producing those points of contact is really important for, one, effective primary care, but also for regaining trust. The reason I think that public health in the US is spiraling downwards really, really quickly, the driving reason for it is that people do not trust the government. By extension, they do not trust public health, and less are they trusting medical expertise. And the reason they don't trust is because we have not given them a reason to trust. They know a healthcare system primarily through bankruptcy, the leading cause of personal bankruptcy. They know it through caustic 5-minute exchanges with a physician who's overstressed. And they know it through CBOs, community-based organizations, nonprofits, where this is where they get the care. Those organizations do really good work. But over the last 4 decades, we have privatized social services to such an extreme degree that this is pretty much the only interface that people in dispossessed communities have. And that does not generate trust that returns to government. It may generate trust that returns to that CBO, which helps them get more grants. And then there are all sorts of perverse incentives, no matter how good intent is within that structure. But it does not enable us to build popular will, to expand public systems, and to build public trust in those systems, without which public health always fails. We need to have trust, and we have to earn it. And you have to do that through robust public systems. So I think providing these contact points where you actually build trust through relationships, not just by saying, trust us, I think that's really important for integrating primary care with public health and ultimately reducing the healthcare needs that people present to primary care providers for.
Well, so you've written a lot about the need for doctors to use their collective power to push for political change. So, what are some of the changes that you see that we need to make to get there, right? What would that look like in terms of providing that access that we're talking about is so lacking in the current system?
I think we lack an effective political organizing model within U.S. healthcare. And it's not for lack of will. I have people contacting me all the time asking, what organization can I join? What can I do? And I don't have a good answer for them. There are a lot, there's smattering of organizations. People are trying really hard, but we have not produced an effective collective model for policy demands. And for the policy demands we need. Part of that is because I think physicians, it's a pretty all-consuming career. This is often the only thing we've been trained in. Is the way we've been trained to think. We've absorbed healthcare-centric ways of thinking about care, health, social relationships, and we're often short-circuiting our imaginations in terms of the care systems that we could build, which exceed the medical model. And that's where we really need to place our demands. And that's not what our institutions are going to encourage us to do, or our professional bodies or lobbies, because that doesn't actually increase their power, or diminish their power. A lot of the work that we need to do to build effective health systems in the US is work that is going to diminish the revenue and the cultural influence and the economic force of the medical field. And there are lots of disincentives for doing that. And I think that has downstream consequences for really inhibiting us from producing the political forms that we need to in order to make the demands that we need, which I think have to be around basic social care systems. Like that is the most important thing for building health in the US. National Academies of Medicine estimates that it's 80 to 90% of factors that determine health are not medical. And so we could get universal healthcare, which I think is really important. We could have more doctors, really important. But even if we do the best we possibly could in healthcare and we don't invest in our social care systems, the gains we're going to get in terms of life expectancy, quality of life are going to be minimal compared to what we could do with the same investment put in these other places. And we need to learn how to organize around that effectively, I think.
Thank you.
Dr.
Rothschild, so what do you see as the changes that we need to see to advance public health? And what would that look like in terms of affecting primary care?
Well, I want to begin with some of the points that both Dr. Reinhart and Dr. Conway made just now, because I think there's some just really rich points that are being made, and I'm really excited about them. One is, I think, the underfunding of care work, right? And so, I talked about deep ideologic structure. If we talk about that, there is a clear sexism built into that, right? That the work of relationship and caring ideologically has historically been associated with women. So therefore, in a male-dominated society, you have this undervaluing of the relationship work, of the care work. So, it's a deep structure embedded into it. Part of it is also the narrative. I haven't done it in the last couple of years, but historically reading medical student applications, that, you read about, we train them to become the hero of their own narrative. And whatever situation they're in, somehow they become centered in it. And none of this work, none of these problems we've just described are going to be solved by some courageous, physician. It is collective action that is needed. Otherwise we will never, move this. And so we're already, pipelining or attracting or rewarding a very narrow band of individuals, and based on this individualistic ideology. The other 2 points I wanted to make was, one was actually was the relationship of trust. And as someone who, has had the, experience this just this morning and seeing patients, of seeing the great grandson of a woman I first took care of 15 years ago, who had a major depressive crisis, and, worked her through her depression, got her on the right antidepressants, then became her daughter's doctor. And the daughter said, "Oh, my daughter's giving birth today across the street. Can they be your patient?" And so I saw that, that the fourth generation of that family, and suddenly the mom of the baby is breaking down and talking about trauma in her life. And she says, "I don't talk about this with anybody, but you saved my grandma, and she said I should come to you." That's trust. And that's the stuff that won't happen in a transactional model of healthcare, which is where the system is going, where we, are widgets, we are work RVUs, it's crank people through, et cetera. And that is longitudinal. That's a luxury I've had in my career, but it's also one of the pieces that avoids, the moral threat, or avoids the burnout problem, because you have trust. One model that I'd say does pose a solution, or at least one solution, and our colleague Bonnie Ewald pointed it out in the chat, is the teaching health center model. Dr. Conway said academic health centers need to take the lead. You are asking somebody who is addicted to specialty care to solve the problem. They are not putting down that crack pipe. We want more of those high value orthopedic procedures. They are not going to be advocating. But what the teaching health center model does, and was first introduced 12 years ago by CMS at the advocacy of family medicine and other specialties, was no, stop giving the money to hospitals. They're going to do, hospitals going to do hospitals. Give the money to community health centers, which are required by law to have a 50% plus board made up of community members, and train primary care clinicians there. So Illinois now has 3 of them. Erie Family Health Center was the original one. In the last couple of years, Lawndale Christian became the second, and our own Rush Esperanza residency is the third. And now we're getting, here we get residents. Esperanza, in our partnership made very clear, we do not want to have a single resident who isn't fluent in Spanish, because we serve that community. So 100% of our residents are either Latinx or Afro-Caribbean and speak Spanish. They spend their first month going out with community groups and, going on home visits and seeing what's happening on the ground, and not seeing community, which is the other thing that sometimes happens, because we're physicians. We look for pathology, we identify community pathology. Yeah. By flipping the training, you start to go, wait, what are the community assets? How are people surviving in what is essentially a dehumanizing, unsurvivable situation, and yet they're surviving? So by flipping the paradigm into a community-led residency, you now start to have the potential to produce clinicians who are not going to replicate the problems that we've seen in the past.
Thank you.
Sorry, that was a long way to get there, Dr. Fegan.
Dr. Conway, I want to give you a chance to respond to that as well.
No, I like what both Dr. Reinhart and Dr. Rothschild just shared. I am familiar with with Lawndale Christian Health Center and their newish program. I think they may be going into the 2nd year now. So no, I totally agree with that. I do think that's a wonderful model. As a person that comes from the community and runs a community-based nonprofit, I think community everything. A lot of times people ask, how are we successful at so many of the things we do? And I said, because we are we are firmly rooted within the community. We're listening to our parents. Our volunteers all come from the community. So I am 100% in agreeing with that. I do think, though, to your point, though, Dr. Fegan, you can incentivize at least and require academic institutions to do their part too. I'd hate to have to wait for community programs to be the only lead. I do think there should be a demand and expectation on the part of our academic centers, because they are being funded by our taxpayer money through Medicare. And I agree with you, Dr. Rothschild. I do think academic centers, they are a corporate type of entity, so they do function that way. But I do believe that since they have a heavy reliance on on residency spots, there should be maybe a model that incorporates both. I think everyone is responsible. And I do also, because of what I do as a person who is really getting kids that are from the inner city communities of Chicago and the metro area into medical school, and doing it the hard way. I do think, and I really wish that there was more support coming from our government in terms of those types of dollars to really get our kids in a position, to actually be able to provide this care, become physicians, become healthcare leaders and healthcare workers. I do think there needs to be a comprehensive model that looks at all of this.
So Dr. Conway, you've anticipated my next question, because that's the focus of your work at I Am Able, is supporting these young folks who are coming from these historically and contemporarily excluded from healthcare, right? The math and science careers, so they have to overcome these inequities. And so the future of healthcare is really going to depend on a robust, diverse workforce. And so how would you characterize the state of diversity of primary care in particular? And what programs don't exist that you would like to see now to support young people who are entering into health careers? And you could go ahead and say why you think they're not happening now, so we can begin to talk about what we need to do next.
There's no true interest, no true investment. It's just to keep it real. I have been told to my face by academic institutions that no. And the answer is no, and no, we can't, and no, we can't. And so the way that I have gotten around that is really just finding individuals, as we say, the power of one. I've been able to find one individual here at this institution that has a little bit of leverage, and that one person has leverage, and the next thing you know, they're like, oh, who's I Am Able Foundation? Yep, we're here. And it's because of one person that was in that group, not the people at the top of the food chain, but actually some people in the middle who recognize the need. And so one thing, I think that even though this is not exactly your question, I think we all have to recognize the power that we have as individuals to create true change. So when you start talking about some of the real needs, let's just face it. For example, Black people in specific, when we talk about that community, they represent 5% of practicing physicians in the country. Why is that not a crisis to someone? That should be a crisis to everyone. And these are the same people that by definition that I just described will go back into the community. I'm not unique in that way. That was my first charge, was to go back to a community like the one I came from. But yet there is no true investment that's coming from academia, coming from our government at all. That's concerning. And when you look at Black men in medicine, the numbers there are 2% of practicing physicians. In fact, on Thursday, May 18th, we're going to have Black Men in Medicine event at our 6th annual Chicago Health, Medical, and even Law Career Citywide Student Conference, so that we can bring in some of our thought leaders, Black men in medicine who are out there practicing, so that they can meet some of these younger Black men in medicine, and it's all of us sit down and think about ways that we can change things. I always say that you cannot be what you cannot see. And so when we're looking in our communities and there's no one that looks like us, I think about my own life growing up in the Inglewood community of Chicago. The first time that I personally saw a doctor was at 16 years old. How do you get a chance to be something that you don't get a chance to see? And it was just, as I say, but for the grace of God, that some mentor in the CHAMPS program, I was able to, because I had this quasi idea that I want to be a doctor, never saw one, never went to one, ever, until I was 16 years old when my mother had healthcare insurance. And I think that people don't want to talk about the impact of poverty on our communities and how our socioeconomics impact the ability for us to even train within our community. So when I think about the things that are missing, Dr. Fegan, I have to go back to the fact that there is not a governmental push to make sure, I don't think an adequate one anyway, to make sure that communities that are underrepresented, that we can actually create true pipelines. Because it's one thing for me to actually be able to prepare people and give them the type of, STEM support and all the things that they need, but it is another thing for academia to open up the door. And the interesting thing about I Am Able Foundation and some of our struggles is that a lot of the support that we have had has not come from governmental grants. Those have actually been complex. They've actually been parceled out to people in advance of you applying. So you really have no real access to that funding. And honestly, the monies that we have has been because of hard work on my part to reach out to people and find people who care about the mission. And it's mostly been people from the private industry that saw a need and said that they wanted to make a difference. But where does our government take responsibility? Like, what is their responsibility? You have kids that are growing up in the inner city of Chicago in poorly resourced schools. It is not possible. We talk about, raising yourself up by, pulling yourself up by your own bootstraps. But as Martin Luther King says, what about the people who have no boots?
There you go.
So there has to be an investment in the community of these poorly resourced schools. And I think the harder solution or the longer solution will be to change our schools, right? We've been talking about that forever. That kind of goes back to Dr. Rothschild's point, that's kind of focusing on corporate structures and waiting for those types of change. But we can invest in community-based solutions, people that are getting it done. For example, last year, I'm Abel Foundation got 8 kids accepted into medical school out of a small list that were in a position to actually apply last year. We have hundreds of kids in the program, but not all of them are eligible to apply. What did we have to do that? I had to develop an MCAT program from the ground up that was sensitive to the needs of vulnerable populations. You can't treat them the same way. You can't assume that they had physics and that they had this and they had that, and all you need is a Kaplan course, and that should do it. You have to think about the fact. Let me give you an example. One of the things we did for our MCAT program with the help of Northwestern Medicine and other outside funders, we actually recognize the fact that Black and brown kids from impoverished communities cannot take off from working for McDonald's or Portillo's and the other places that they're living to study 10 and 12 hours a day. They cannot stay at home with mama because mama doesn't have a house. So how are these kids that are 23 and 24 years old that want to become a doctor, do not have the infrastructure and the support? How do they get a chance to do it? Well, I Am Able Foundation, with grants from other nonprofit foundations and the generous support of people in our community, what we were able to do was offer stipends to start study. Our kids would study full-time at Northwestern for 14 weeks during the summer. And then we would give them a stipend of $4,000 just to study. So we tell them, no, you don't have to work. You don't have to do anything but show up every single day. And when you show up, we'll also give you money to park because it costs a lot of money to park at Northwestern, or we'll give you money to get on the Metro. And these are the things that allow us to actually, because when you set a bar someplace and you really set it, because there's no such thing, I think Dr. Rothschild can probably maybe attest to this, or maybe Dr. Reinhart also, when they start talking about holistic admissions, please be aware that holistic admissions happens after you rise above a certain threshold. We have to get our kids in a position to be competitive. And one of the things that happened as a result of this very intentional programming is we had kids scoring anywhere. We had 25% of our kids scored between the 80th and the 99th percentile on the MCAT. The 80th and 99th.
I hear you. Right.
These are the things that are needed.
Yeah, thank you. I appreciate that. I'm going to try to get to some of the questions, but I do have to shout this out because Dr. Conway alluded to, and Steve, you put it in the chat, but there are fewer Black men in medical school today than there were when I when I entered medical school in the 70s, unfortunately. And the reality is that 5% number has really not changed in more than 60 or 70 years. So we are really suffering with regard to that. Dr. Reinhart, I'll give you a chance. Do you want to respond to this or add to this conversation before I go to the first question in the chat?
Just, I think that everything that Dr. Conway said is really important. And this point that the government is not doing enough, that's absolutely true. I also think we need to stop with this naive, and I don't think Dr. Conway is doing this, but this naive voluntaristic attitude towards academic medical centers. I've been working with a research group in California, and we're looking at quantifying medical segregation across all hospitals in the state. And the leading drivers of medical segregation in the state of California are the fancy academic medical centers. And this is true, I'm sure, in many other places around the country. And yet these are the places in which you have all of this righteous rhetoric that's constantly fed to everybody. And I don't know who's buying it really, but we're not having legal restrictions or requirements put on these institutions that we should. They frankly should not be they shouldn't have nonprofit status in many instances. And if they are going to have that, we need to have very strict demands upon what they're actually doing to serve communities around them. Because it's become an explicit premise of many of these institutions that they have no responsibility to the surrounding communities. They are academic quaternary care centers, and their proper role is, in fact, to abandon their communities. They don't say in quite those terms, but that's effectively what has been happening for the last 20 years. So this kind of voluntaristic attitude, I think, needs to go. We need to confront the reality of what these institutions represent.
Absolutely. Thank you. So one of the first questions we have from the audience is, what are some of the current initiatives offered to MD students, to physician students, to incentivize them to pursue primary care upon completion of medical school?
I don't know if Dr. Rothschild, I know he could probably speak to this, but one program that I'm aware of that's at Rush and it's at other places as well, is they actually have a shortened track. So people can actually start in medical school and go directly into a primary care track without having to actually go through a matching process, or at least an elaborate process. They're actually pre-selected early on. You're interested in pediatrics, you can cut down your time. Rather than being in this program for 8 years, you can actually be in there 6 years and cut down some of your medical school debt. And that is an incentive. However, again, the burden is going to be that this certain kid is also going to have to be strong enough academically to be able to cut an entire year and accelerate their course. So once again, there's going to be some inequities as it relates to that, but that is a start. But I don't think that applies to many of our vulnerable populations.
Unfortunately, they established the National Health Service Corps because when I finished I went into the National Health Service Corps, and the time I went, it paid for my entire medical school. And not only paid for my medical school, I came out of medical school with no debt. It covered my books and fees. So it was never an issue for me. But Reagan's cut that program. And now although there's some, it's a tiny compared to what it was at that time. And it's more of a loan repayment plan than giving people a free ride to medical school. But Steve, do you want to comment on
No, I think I was going to comment on National Health Service Corps exactly as a model that worked. We do not actually have that accelerated track, Dr. Conway, though we've been talking about it.
Oh, it hasn't started. Okay.
It has not started. As a graduate of a 6-year program, it does make a difference because it has to do with how much debt you graduate with. Ironically, the dollars, though, like NHS, like the National Health Service Corps, there are dollars for NIH investigators, physicians who are NIH investigators, to get loans, written off, or to get subsidies after the fact. There's the military scholarships, but primary care, there are few and far between.
Yeah. So I have the next question I have is about the corporate investment in primary care from insurers and retailers and private equity groups as well. And so assuming that we disagree with that, what is the affirmative alternative vision? So what is the correct organizational and payment model that would take us where we want to go?
Well, I'll start with that because I was thinking about that, and I know somebody raised that earlier. I mean, the corporate takeover is capitalism at its finest. You find an undervalued resource, and you dump some money in it. This is home flipping, this is how this works, right? And so what we need to do is call out the underfunding of primary care and bring the resources needed, which really means not paying on a widget by widget basis, visit by visit, but on a population basis by the government. It's the NHS model. Okay, you take care of a population of 1,200 and you have these resources to do it, and you invest adequately. That, however, is, just even saying it aloud, somebody is going to put in there that, Dr. Rothschild needs to have drug testing done, because that's not how we do things in the United States.
Yep.
This is movement work. This is, going to require collective action, both by patients saying we're fed up and physicians saying we're fed up with this. And that's, that really is what's necessary to change this dynamic.
Thank you. Dr. Reinhart, you look like you wanted to say something there.
Yeah, I mean, Dr. Rothschild said it, so I can say it. Capitalism doesn't work for healthcare. We need to transform the model. We need public systems. And we can't persistently kick the can down the road by just delegating to nonprofits. What you've had at departments of public health around the country, and Chicago is no exception, in fact, they might be one of the leading examples of this, is public health departments turn into grant-making agencies for all these CBOs. We have not built public infrastructure, and we should absolutely have public infrastructure for primary care and connecting basic community-based social care with primary care. That transition is an essential task of public health, and that's direct service provision. That's not biosurveillance. You actually have to employ people to do that, and they should be publicly employed to do that. And how are you going to do that when right now CDPH, for example, gets 10% of its budget from the city and relies on 90% from federal dollars that they can't really do much with because they're already tied up? You have to have a big capital campaign. And this is not just true in Chicago. You have to have this across the country. You have to have real demands for reallocation within municipal budgets. There's also some creative possibilities. So there are very few actors within the healthcare system who actually have an incentive to reduce costs. Payers are pretty much the only party. So Dave Chokshi, who is the former commissioner in New York, he put in JAMA a proposal for public health bonds, where you come to arrangements with payers. Now, there's some risk in this because you don't want to entrench a perverse structure we already have, but somehow it feels like wherever you turn, you're always doing this. So you have to be aware of what you're doing. But an interim possibility is working with payers to come to contractual agreements where we will provide these kinds of basic preventative services to this population with an anticipated return to your organization of this amount. You invest the money. And we'll do this. We have to have some real fundraising. And I don't want to rely on philanthropy or on private insurers, but the reality is we don't have enough capital within the public systems right now. We have to get creative and ambitious about how we do these things. And then when we have capital, we can build public infrastructure to give people not just primary care opportunities, but ones that feel rewarding. A lot of primary care work does not feel rewarding because you're working with institutions that exploit you, that do not support you, that are not surrounded by community health workers and proper nursing staff and techs, and you're not integrated into communities. I mean, imagine if we could build city-run clinics, city-run integrated service facilities where you as a primary care physician are working alongside your neighbors and you're given a stipend to live in that community, to incentivize an integrated care model. We could do this kind of thing, but we have to generate the funds and the will to do it.
Yeah, so someone asked, is single payer even enough anymore? And so what are my thoughts about a completely nationalized healthcare system? Well, that's exactly right. And so Dr. Reinhart, part of what they do in the Cuban system is no one is allowed to go into a specialty until they have practiced in primary care for a period of years before they're then allowed to request the opportunity to go into specialty care. And when you go into primary care, you have to live in the community that you're serving, right? And that you're coupled with whether it's a nurse and a PA or APRN, or, so that there's a team, because, as we said at the beginning, we talked about primary care being an essential public function, but it also is teamwork. And so it also requires not just one provider at the head, but a team of folk that are going to meet the needs of the public. And so no, single payer is not enough. It levels the playing field. It's beginning to say, everybody, I heard mention about, well, we have to convince the payers to do this. No, we need to have one payer. And, if you look at the overhead that the insurance industry takes out for healthcare and for advertising and for the other non-healthcare function with the premium dollars, that's why you have, if everyone paid into one pot and we use that for this paying for the health care, and healthcare being a broad term, talking about what the needs are of a population. If you look at the Canadian system, they have regional planning boards that decide what the needs of a particular community are, because how you would spend your healthcare dollars in the city of Chicago are different how you would spend them in Miami, and different from how you would spend them in the Bronx. The system and the problems that the country is facing. It varies from community to community. So single payer is not enough, but it's certainly a start in terms of leveling the playing field. Because right now, if you have enough money, you can get the care you need in this country. But if you don't, we are struggling mightily, and we don't all have equal access to the problem we're dealing with. So we have a question about, when looking at primary care, what are physicians doing to assure that people are listened to with the sensitivity and sophistication within healthcare? And I think that's something that Dr. Conway has alluded to, when she talked about you can't be what you can't see, in terms of, I know the difference it makes when I walk into the room with my patients, or even when I would make rounds in the hospital. And I would come in with a team of residents and medical students, and I would see this huge smile come across the face of a Black patient. You're in charge, and it makes a huge difference. But what are we doing to make sure that patients are heard, and that we're sensitive to their needs? I heard Dr. Rothschild talk about a traumatized patient. I hear Dr. Conway talk about some of the challenges of the patients she sees. But what are we doing to address or assure that?
I think go ahead, Dr. Rothschild.
Go ahead. No, go ahead.
I'll say that one thing we often lack in our care systems in the US is participatory or reciprocal care structures, where the people who are being cared for are also involved in the work of caregiving. And part of listening to somebody is having some kind of lived experience that gives you the capacity for a genuine empathy, not the kind of empathy they teach you in medical school to respond with, I'm sorry, or that kind of thing, but real empathy that's rooted in lived experience. And part of that project of producing those kinds of participatory reciprocal care structures is what Dr. Conway has spoken about: recruiting physicians, supporting people to become physicians out of these communities where they actually have that lived experience. But it's also, again, I'm repeating myself, expanding who we're imagining as listening. And that a lot of the listening work that primary care providers are doing right now, they're doing because there is no other prior caregiver in the structure. And in fact, primary care physicians are probably not going to be the best listeners for many people in relationship to their trauma and their everyday life experiences. And neither are a lot of therapists. The idea that we've kind of medicalized or professionalized all of these caregiving structures, I think, is part of why our capacity to hear now, it's different to listen and to actually hear somebody. Our capacity for hearing people has really declined. And I think we have to reimagine who it is that should be doing this work.
Yeah, so that's an interesting thing, but it's been written about for years, is that, because, and Dr. Rothschild talked about, people, it's such a short time frame that you have with a patient, and the studies that show that the patient starts to explain what the problem is, and the doc kind of wants them to get it out because they have to get on to the next patient that they have to see, and so that they've already made up their mind within the first 60 seconds about what they think is wrong. And it turns out it's really what's really wrong is when you're reaching for the door to leave and the patient says one more thing, or I just wanted to ask, or I just wondered. And that was what they really wanted to ask. But, it's talking about, alluding to the fact that women often may not feel that they've been listened to or they've been heard. And what I always tell the residents is that you will never, ever take care of a patient. You will teach a patient how to take care of themselves. And the only way you can do that is by hearing what they have to say and meeting them where they are. And we talk about that a lot at County, is trying to meet patients where they are. We have a couple of questions that talk about capitalism doesn't work for advancing health equity. And so what's an alternative model for healthcare that excludes capitalism? And so, and what's needed to spark that shift? I think that's part of what I'm talking about when I talk about universal healthcare, because that's not a profit-driven decision-making. I think that that's the huge problem, is that we, people, one entity is always trying to climb over the other. And, in Chicago, where we have 7 medical schools, and my God, they're all trying to stand up, cardiac surgery. Right now, they're all trying to stand up a stroke service, or they're all trying to stand up because, where is the money right now? So it is absolutely true. As long as they're competing with each other, they're going to build bigger and brighter buildings instead of dispersing people out into the communities that they're trying to serve. But I'll allow any of the panelists, if they want to take that on in terms of the alternative model.
I guess I want to say, we use capitalism in this context, but in some ways the irony is this is actually in healthcare, we don't work by the law of supply and demand, right? There isn't as much, there's an enormous demand for primary care and a relative paucity. There are an overabundance of dermatologists, and yet they are the highest paid specialty. So it is the incentives. There's been a little bit of thumbs on the scale, and I'm not saying that we just need to fix capitalism, because that's not happening. But in its purest form, we wouldn't be having this conversation. So it is by its very nature, I think, prone to corruption. I think it is reframing what we mean in healthcare as a public good, and that really is a single payer system. And
we accepted that with education, right? We accept that with fire protection. We accept that there are certain goods that society is incumbent upon to provide for the population, and that unless we take care of all of us, that there is not either all of us or none of us, right? We're not meeting the needs of a society as a whole, unless we are able to address the needs. And equity is not about giving everybody the same. Equity is about giving everyone what they need and what's necessary. And so what's necessary in Inglewood is different from what's necessary in Evanston, and it's different from what's necessary on the west side of Chicago. And so we have failed to accept healthcare as a right. It still remains a privilege in our society. And so that's a huge part of why we can't fix it with what we have. All right, someone has asked about how do we address the issue of many Black residents being dismissed from their programs, especially in the subspecialties. Steve, I'm going to come to you because you are part of a training program.
Yeah, our training program is relatively young and new and has not had this issue. This is a phenomenon in the specialty areas, and I have little or no direct knowledge, but I do think this is a question that needs to be asked of every program director in the country, and have them account for themselves, because it is something obscene, and it is a disturbing trend. I mean, do you guys? let me just turn it back to you, Dr. Fegan. How do you address this at Stroger?
Right. Well, so I'll just go to a historical point. I mean, it's one of the reasons we've gotten away from oral exams for specialty. It used to be that passing your boards, you had to pass an oral exam, and guess what? When we had all oral exams for all the specialties, we had all old white men. We just didn't get women. We just didn't get people of color. And so it's requiring, it's insisting upon more objective measures. However, I would say to you that just passing an exam does not make you a competent or even a qualified caregiver. Because I have lots of folks who score very well on their exams, but don't know how to talk to a patient. And as Dr. Reinhart, they don't hear them either. When the patient, they didn't hear what the patient said to them was the problem when they came in. And so, you know, people of color not being able to complete their training program is related to the structural racism that exists in the system of medical care in this country today, that exists in how we decide who gets into what program. And so it's go right to the interview in terms of who gets accepted into these programs. And people tend to accept people who look like them and sound like them. And as long as the people in charge making decisions is not a diverse workforce. And by the way, it doesn't, you know, when we have diversity in the healthcare workforce, it improves the care that all caregivers give. It's not just that patients benefit from having someone who looks like them taking care of them. It means that by working in a diverse workforce, it has an impact on the care delivered by everybody who participates in that process.
I just have to call out, you know, as little as we have accomplished in many ways, the forces of reaction about the themes that you just talked are in full blossom right now. And I think we need to, you know, recognize that even just the discussion you just had, Claudia, were you in a certain peninsular state of this country, you would lose your job over that, you know, and your boss would lose their job. You know, we say roads are a common good, but yet we have collapsing bridges and roads all over this country. We are neglecting schools. This is, you know, a pushback, and, you know, on every single front, on, you know, making it possible for individuals of color to have better education, to be accepted on their own terms into colleges and medical schools and so on. Pushback against that. We are in a time of great pushback, which I only wish reflect the enormous power that, you know, we have gained. But I think they're making sure, you know, that this doesn't even, the things that we're talking about don't even get close to being realized in any sector.
Yeah, it's not lost on me that I'm the chief medical officer of one of the largest healthcare systems in the country, and was born in a hospital. You know, I'm sorry, as a child was admitted to a hospital to a segregated ward. So I recognize that change is possible, but I also acknowledge it's not inevitable. So I have to ask this question. This is from a member of the Health and Human Services Transition Subcommittee of Mayor-elect Johnson. So this is a lot on the line here. What is the top issue or area within health and public health or health care that you believe Chicago's mayor-elect should address? And please be as specific as possible, because someone's taking notes. I'm going to give it to each of you, and because I think that's going to take us to the end. So I'll start with Dr. Reinhart.
I typed a response to that, but I think the most important thing for a number of reasons is that he really built out the Treatment Not Trauma campaign platform as not just a crisis response infrastructure, which we desperately need and lack, but also as a crisis prevention infrastructure for sustained everyday care. That's a community health worker system with public employees. When you build a system like this, you can integrate the benefits of gainful employment to people who desperately need it, everyday social care, connection to real, more substantive medical care and welfare infrastructure, violence interruption, all of these things that we have across the city, but piecemeal and aren't integrated. Because they aren't integrated, they don't work well. So this kind of a treatment, not trauma workforce, publicly employed, think about it like in terms of the level of work that we give to police officers to really build up communities and generate trust, earn trust where we haven't earned it in the past, I think would be the most important infrastructural shift that he could make. And I think it's an opportunity to have a totally different model of local public health that we need in the US, because we have miserably failing public health systems across the country, and Chicago's, not excelling among these already failing systems. So
thank you. Dr. Conway.
Well, obviously, I have a bias towards pipeline programs. I do think that's important. I don't think that that's small. I wish that, or I hope that there will be further awareness of the need to find the solutions from within the community. We have brilliant young people who cannot get the help that they need to actually give back to the community that they're already living in. I think that is very crucial. Another thing that I'm understanding that—
But be specific in terms of what you would like to see the mayor do. with regard to that?
Support and fund pipeline programs. Also support and fund programs that will help our students in the areas of STEM and sciences, where many of our students are woefully unprepared. As a person that runs a pipeline program, I could tell you that for many years, there were kids in our program that didn't even have books at their school. Books. They were using pieces of paper that was handed to them. And we are actually expecting these kids to compete with kids from other suburban schools. It's an impossible and an unfair ask. We're going to have to do a better job with our school systems. And then we have to also have a focus specifically with STEM and science education. I do believe that's very important. But I also want to add that I understand that he has also campaigned, at least, in regards to mental health clinics. And I can tell you that when I was a young person growing up, even though I didn't have insurance and I didn't need to have a mental health need, I do remember seeing mental health clinics in the community. And they are 100% completely missing. I mean, and they were standalone mental health clinics. I know people out here that have insurance that cannot even get actual therapy. Like people like us on this call have a challenge, even trying to locate someone that will take our insurance and allow us as burnout physicians even to actually get the kind of help and or therapy that we need. Many people on this call have even used some of the private entities like BetterHelp or some of the other ones, simply because the system, even for the corporate insurers, is broken. So I am hoping that he will definitely make good his promise to stand up these mental health clinics that have been set completely down since the 70s, because I think that some of the violence that we see, or police-involved shootings, at least, of unarmed Black men in particular, there is a component of mental health issues that need to be addressed, and I'm hoping that that's something he'll be able to focus on.
I might put a modifier on that because
Sure.
I'm not convinced that resuming the mental health clinics will be the solution so much as if we could integrate mental health or behavioral health into our primary care and have that in the community. And the reason why is I know that there's a certain amount of stigma going into the mental health clinics. And so it's true that our patients who were schizophrenic and went there for their injections that met their needs, but there were other folks who might have benefited from seeing a behavioral health provider who might not have felt comfortable going there. And I really don't think that recreating that is going to solve the problem as much as I think that if we had deliver healthcare in the communities to people and have mental health integrated into that, it might be a better model. I mean, because I learned it in training, is that if 60% of the patients you saw weren't there for a behavioral health problem, you probably weren't asking the right questions. And
oh, sorry, go ahead.
I want to give Dr. Rothschild a chance to answer.
I would just say, both Dr. Reinhart and Dr. Conway identified sectors, and it really reinforces our friend Linda Ray Murray's dictum that everything is health. So it is about policing and schools and everything. Mental health needs to be a core part of the public school system, because that's it. I would add one more public good, which is essential to health, which is housing. 15,000 children in Chicago public schools are not adequately housed. There are some 70 to 80,000 Chicagoans who are either sleeping out of doors or surfing on somebody's couch. You cannot be healthy without that. So if we're going to address these issues, it's about all of these sectors and really taking an intergovernmental agency approach to healthcare. And so I'm hoping that Mayor Johnson, and I'm glad to see he's on the call, is connecting the dots with all of the agencies, Housing, Human Services, and CDPH.
Thank you. This has been a very rich discussion. I thank the panelists for their time and commitment to this issue. I want to try and it's 3:00. We've reached our time, and I want to thank everyone for their participation. We've had a good participation from the folks who are watching, and the panelists. Your thoughts have been helpful and enriching. And I think that we need to carry these issues forward. So thank everyone. And Health and Medicine Policy Research Group, thanks you for your participation. I think that this is a discussion that could go on for hours, but we have scratched the surface and tried to raise some issues that are important in addressing the primary care crisis in this country today.
Thank you, Dr. Fegan.
Thank you.
Thank you, Dr.
Thank
Fegan.
you.